Hi, Dr. Windisch again. Welcome to our video series for students. Remember that we can be reached for scheduling rotations at 775-359-7111. Today we're going to talk about a personal pet peeve of mine, and that is management of UTI in a child. At least in this community it's done poorly, often as not. So off video you're going to hear some disembodied voices. Student number 1, number 2, and number 3, they've asked to remain anonymous, and so they shall. So student number 3, tell me, how do we diagnose a UTI in a child? What are the diagnostic criteria?
Okay, well, the gold standard right now is a culture of the urine specimen.
Okay.
So, with a clean catch, 100,000 colonies per ml.
Okay.
For catheter specimen, 1,000 colonies per ml. And a suprapubic growth, any organism that's
okay.
seen.
Because suprapubic is, by definition, going through a sterile field. So a couple of caveats. I want to stop you there for a second. A couple of caveats. Number one, you must culture. Okay, 15% of kids with UTI have dip negative for bacteria. So you miss a lot of UTIs if you're only looking for leukorrhea. And kids don't concentrate their urine like adults do, so it's not very common to actually see a positive nitrite on a dipstick on a child. Number 2, conspicuously absent from that list of diagnostic criteria is what sort of specimen, students number 1 and 3, or 1 and 2?
Bagged.
Bagged specimens are conspicuously absent. In fact, the article that I gave you to read is pretty clear about the worthlessness of that. If you get betadine in the bagged specimen, it'll sterilize the specimen, so you get false negatives. And, of course, false positives are through the roof with that. That's a real good way to know what the stool is growing, but not much else. You absolutely, positively must, if the kid cannot pee in a cup, stick a catheter in their bladder. And if you can't do that, stick a needle in there. And if you can't do that, have a radiologist do it under ultrasound guidance. Okay, so now that we've diagnosed it, by definition this is a complicated UTI. So by definition this must be treated for 10 to 14 days. By definition this is treated with high-dose antibiotics. And most of the time we assume that this is a pyelonephritis because you're not going to get a good story from the kid. All right, now once you've made this diagnosis, a certain percentage of patients need to be worked up further. What's the workup and who needs it?
Not sure.
Well, what's the rest of the article? So what's the rest of the article talk about?
Well, it's talking about imaging.
All right, so who gets imaged?
Well, anyone who's gotten their first UTI.
Not anybody with their first UTI. Any male with their first UTI, absolutely. Okay. Because boys shouldn't get UTIs. Okay. All right, which girls need to be worked up?
Not sure. Is it
students number 1 and 2?
With a recent history, a previous UTI.
Okay, so any girl on multiple UTIs. Who else? What girls with their first UTI?
Under 3.
It depends on the literature you're reading. Definitely under 2.
Under 2.
Some people say under 5. Or some people say under 3 or 4 or 5. I say under 5.
Under 5.
So my rule of thumb is if you can't count their age, if you can count their age on your fingers, you probably, on one hand, then you probably need to work them up with their first UTI. Definitely under age 3.
Okay.
I would also argue to you if you have a 5, 6, 7-year-old who has a history of a lot of ear infections or a history of a lot of strep throat, they need to be worked up because chances are, unless you were the one who diagnosed those strep throats and you diagnosed it the way I taught you to diagnose it, and that's with a positive rapid strep, and unless you diagnosed those OMs personally or an ear, nose, and throat doctor did, and you did it the way I've taught you to do it with insufflation, there's a good chance that a lot of those ear infections or strep throats were not and were in fact UTIs. Leading to one of my favorite sayings, the most common cause of a UTI or of renal failure in this country is what?
An ear infection.
is recurrent ear infections. Students always scratch their head and they go, I don't understand the connection. There is no connection. That patient didn't have recurrent ear infections. They had recurrent renal infections that were always blamed on the ear. Okay, so what kind of imaging is available? What kind of imaging should we do?
Okay, well, there's an ultrasound of the kidney.
Okay, that's available. We'll come back to that one in a second because that's become controversial.
Voiding cystourethrogram.
VCUG, okay. And then the DMSA scan.
Yeah, those are the three mentioned.
The article talks a lot about DMSA scans. Their biggest utility really is in recurrent UTI looking for scarring.
Okay.
So any kid who's had a recurrent UTI or who's got UTI with history of recurrent strep or middle ear infections gets a VCUG to look for renal scarring. I'm sorry, gets a DMSA scan to look for renal scarring. Everybody gets a VCUG because that's going to look for vesicoureteral reflux. It'll pick up a lot of your ectopic ureters. It'll pick up just a lot of the renal abnormalities that go with this. It won't pick up 100% of ectopic ureters. Sometimes they're a little bit tricky. The utility of ultrasound, we used to do it routinely. It's now been called into question as its routine value if you have a normal VCUG. If you have an abnormal VCUG, you really want to ultrasound the kidneys because you want to look at the cortex of the kidney. But if the VCUG is normal, do you really need to look at the cortex of the kidney? Is that going to show you anything? And the answer is probably not. Having said that, here in Nevada, considering the standard of care, I would ultrasound everybody as well. Just to avoid medical legal issues.
And then the VCUG, that's done as soon as diagnosis happens?
Can be done as soon as the patient's diagnosed. So you can do it, if you put them in the hospital, you can do it in the hospital before they leave. Otherwise, you can do it as an outpatient, and you can do it while they're still on antibiotics. Personally, I keep them on antibiotics of some sort until the VCUG is negative. The question then becomes, what do you do with a positive? Number one, I recommend referral to urology, regardless of where you're at, and regardless of how minimal the reflux is, because that patient does need to be followed to make sure that the reflux gets better. And grade 1 reflux, grade 2 reflux, you can probably manage in primary care. However, your chances of having that patient be lost to follow-up are too high. When you send them to urology, it makes it much more real to the parents, and your chances of having them lost to follow-up are much less. Furthermore, they just honestly aren't going to trust you or believe you until they've seen the expert in reflux. And they'll start seeking second opinions. It's better if you're giving them the second opinion up front with somebody that you can trust who actually knows what they're talking about, instead of some witch doctor down the street. That way you get to control the referral and make sure they see someone who actually knows pediatric urinary tracts. Grade 4 reflux definitely needs to be managed with prophylactic antibiotics until it resolves, and if it doesn't resolve, and often won't, it needs to be surgically repaired. Grade 3 reflux probably needs to be treated with prophylactic antibiotics. Grade 1, grade 2 reflux, again, this is becoming controversial. Here in Nevada, we still put them all on antibiotics, but I think most of the people in the country are just watching the kids, because in low-grade reflux, prophylactic antibiotics really hasn't been shown to be all that effective. And it almost always resolves on its own anyway, so are you doing anything for the kid other than culturing for antibiotic resistance? And the answer is probably not. So that's UTI in a nutshell. It is, recurrent UTI is worldwide the #1 cause of renal failure in kids, and there is zero excuse for it in this country. If you're not sure what's going on, get a urine, and that urine needs to be an appropriate specimen. Any kid who's had fever for more than 4 days needs to have a urine. Any kid who's under 1 or 2 years of age with really high-grade fevers, over 103.5, needs to have a urine unless they're influenza positive. Any kid where you're not sure what's going on needs to have a urine. Nobody likes putting catheters in these kids, but it beats the heck out of putting a peritoneal dialysis catheter in this kid later. Do them the favor, protect them now.
All right.
So, this is Dr. Windisch from Sparks Pediatric and Adolescent Medicine. I hope this has been educational for you. We'll see you next time. Give us a call if we can help you here, 775-359-7111.